This is CNS infection number 2, prepared by Prof. Sharaf and revised by Prof. Rami Edward. Tuberculous meningitis is a primary infection due to hematogenous spread associated usually with miliary TB. Structure of small tubercles may form tuberculomata. There may be hydrocephalus because of meningitis or tuberculomata including exit foramina, and could be associated with infarcts of the thalamoperforates or medial lenticular sterase distribution. CNS tuberculosis is a serious problem in underdeveloped countries. It gives off meningeal, parenchymal, and others. Meningeal, 3 to 6 months after the primary infection. We have the typical meningeal enhancement with infarcts and hydrocephalus. Parenchymal disease, either solitary or multiple tuberculomata, with or without meningitis, seen as round or lobulated, contrast enhancing with moderate edema. Occasionally they may calcify. Other manifestations may include miliary pattern of the TB or abscess formation. Here is the typical tuberculous meningitis, which is usually basal, and here it is associated with ventriculitis and hydrocephalus. So it is basal, may be associated with ventriculitis and hydrocephalus, plus minus infarcts. Here is basal meningitis of tuberculosis, seen as hyperemic and markedly intensely enhancing basal meninges, both in axial and coronal, resulting in hydrocephalus due to ventriculitis and the obstruction of the exit foramina. Basal meningitis with enhancing basal meninges, ventriculitis and hydrocephalus, bilateral infarcts of the basal ganglia, basal meningitis with enhancing meninges, hydrocephalus due to obstruction of the exit foramina. Enhancing lesion here, multiple enhancing lesions with target appearance or without, solid or cavitating, is infarctions with multiple masses, with multiple miliary shadowing involving the whole parenchyma, associated with the typical basal distribution of tuberculomata, which are seen as small solid masses or small abscesses. So we have the tuberculomata, which could be small, could be large, could be targeted, cavitated, could be solid, and may calcify sometimes. Multilocular abscess is typical for tuberculosis, associated with massive edema, and have the same features of abscess formation, that we have a smooth uniform wall. The edema is extensive and there is definite meningeal enhancement, denoting associated meningitis. And here the area involved is very big due to devascularization or hypoperfusion of such area due to associated spasm of vessels, denoting an infarct, and there is push of the midline a little to the other side. These are all stigmata of TB. Multiple tuberculosis appears as miliary shadowing, again miliary shadowing, nodules of high signal in flare and enhancing in contrast T1, but no restrictions. These are not abscesses. In TB and fungal pachymeningitis, we can find this basal enhancement with involvement of the parenchyma, that's pachymeningitis. TB and fungal pachymeningitis here, meningeal enhancement, basal, with involvement of the parenchyma and infarcts formation. So we have solid enhancing tuberculomas with infarcted areas around, and basal meningeal enhancement. This could not be differentiated for TB and fungus. Fungus infection are due to immune compromised conditions. Children with cancer, surgery, trauma, premature infants manifest by seizures and stroke-like symptoms. Common organisms are many. Amongst are the histoplasmosis, coccidioidomycosis, blastomycosis, and cryptococcosis, as well as aspergillus, and most are angioinvasive. Patterns of involvement include hemorrhagic infarction, meningitis, ependymitis, cerebral and cerebral microabscesses, and mycotic aneurysms. On the left, these are hemorrhagic infarcts. In the middle, these are cortical and meningeal enhancement. On the right are multiple white matter nodules, like miliary shadowing. So these are different appearance of fungal infection, hemorrhagic infarcts, meningeal or pachymeningitis, and miliary shadowing scattered within the parenchyma. Fungus may show cyst formations. Cystic changes as bilateral subdural emphysema with enhancement, meningeal enhancement, pachymeningitis, and hydrocephalus with cystic encephalomyelitis. Disseminated aspergillosis may show similar to abscess formation but of irregular pattern. Edema is minimal, multiplicity is usual, solid and cavitating lesions are seen, both solid and cavitating lesions. Ependymitis, histoplasmosis may show as calcific nodules plus widespread infarcts on both sides. So calcific nodules and widespread infarcts are due to fungus infection usually. In toxoplasmosis humanoid, the basal ganglia are common sites. The most common CNS reactivation infection in AIDS is toxoplasmosis. So in AIDS, we have multiple infarctions and we have toxoplasmosis at the basal ganglia. The small size and multiplicity of the regions favor toxoplasmosis more than lymphoma. Mainly we have toxoplasmosis nodules starting here at the basal ganglia in AIDS patients, multiple small-sized widespread toxoplasmosis. Now in cryptococcosis we have the famous gelatinous pseudocysts, cryptococcosis, and this also similar but not identical to cysticercosis cysts. And here we have the very wide Virchow's rubens filled with Cryptococcus cysts. Enhancing lesions are toxoplasmosis, this one, but never mind about this. Think about that one, cryptococcosis. That's similar to cysticercosis. In lymphoma, we have bilateral on both sides. We have patient with AIDS, large size and solid enhancement, and these are not seen in toxoplasmosis. So the difference between lymphoma in AIDS and toxoplasmosis in AIDS is the size of the lesion. Toxoplasmosis is usually of small size. Parasitic infection includes cysticercosis and others. Of course, the number distribution, the character could be seen. Hydatid is also considered, is to be considered. Most common parasitic infection are the hydatid, and we have, as epilepsy, we have parenchymal, leptomeningeal, intraventricular, spinal, as usual. Imaging appearances are variable. Cysts, you have cysts with nodules or no inflammatory response. If died, we have intense inflammatory response. If healing, the cyst shrinks. If healed, these will become calcified. Findings vary with age. So, for example, neurocysticercosis, seen as cysts, typical cysts. Neurocysticercosis, we have variable cysts with nodule, no inflammations, and as we said, the dying larva with intense, healing with shrink, healed with calcified, and according to the stage, neurocysticercosis, well-defined small cysts. Multiple late neurocysticercosis with calcification. Cysticercosis may creep on the meninges surface, and it is called subarachnoid racemose cysticercosis, and this gives an appearance maybe similar to cryptococcosis, another differential for the creeping cysts along the meninges. Subarachnoid racemose cysticercosis is to be considered with the differential diagnosis of cryptococcus. Here it is, subarachnoid racemose cysticercosis. Now we have multiple cysticercosis cysts with massive edema surrounding. That means that it is the dying larva. Dying larva gives intense tissue reaction. Thank you.